Hello and welcome to Sensei podcast. This is Manos Brilakis discussing with leaders in the field of CTO and complex PCI. Sensei means teacher or master in Japanese. The goal of the Sensei podcast is to help you learn and improve in CTO and complex PCI so that you can become the best that you can be and offer your patients the best possible results. Hello, everyone, and welcome to Sensei Podcast. It is my great pleasure to introduce Dr. Jeff Moses, who needs no introduction. He's one of the fathers of the field of complex intervention and actually the one who coined the term CHIP, as hopefully he'll tell us more information down the line. Mm-hmm. He is a professor of medicine at Columbia University, director of interventional cardiovascular therapeutics at Columbia, and Advanced Cardiac Intervention Center of Francis. So, Jeff, thanks again so much. Super excited to have you on the podcast today.
No, I'm great. It's great to be here, Manos. Thank you for inviting me.
So, Jeff, tell us a little bit about how you got involved into this. You've been doing this more than most people I know, yes. And you've done a thousand of cases. But how did you get involved into the complex area? What made you want to go into these areas? And
it's funny. It was actually forced upon me. I actually gave a little lecture about this to the fellows at the fellows course in Florida a few weeks ago. When I was at Cornell as a very junior faculty, remember back then fellowships for 2 years, that was it. You were out there knowing nothing. And CA program going at Cornell. But a few blocks away was this guy called Simon Sturzer, who only did the first angioplasty in America and actually the first angioplasty in humans. And he was a superb operator, and anyone with any common sense who lived in Manhattan would go to him. By then he had hundreds of cases, I only a handful. So I ended up started with surgical rejects. And there you go. It's like we're full circle, right? I mean, so you had the surgeons were happy to have someone to unload these horrible cases to. And we had obviously the tools we have to do. And we had obviously the tools we have are very primitive, but we did pretty well and we learned a lot. Obviously, what we really learned was all the shortcomings, which of course led to all the development of all the technologies and pharmacology that we've enjoyed over these several decades. But that's really got in. It was a matter of necessity. So that's how I started.
But necessity is one thing, but at the same time, I'm sure the surgeons wanted their patients alive, right? So you had to deliver as well.
Well, yeah.
And as you said,
we gave them a good enough product. Yeah, for sure. No, and look, it was also quite gratifying because it was a very primitive era. There was a lot of debate. People don't remember between Grunzig and Hartzler and how far you push the envelope. Hartzler was doing triple vessel disease. So these are dynamics that, frankly, I don't think have really been well documented, and probably should be for legacy. But I sort of, obviously you can imagine I leaned towards Hartzler despite my respect for Grunzig, and we were pushing the envelope out of necessity.
And then, as you said, the equipment was not the same as what we have now, which you were part of developing it.
Yes.
And the rate of complications was much higher, I presume, than what it is currently.
Oh yeah.
So how did you get through this early days where things were just going in, it was complex and the complications were much worse than they are now? Was it just determination? Was it talking to other people? How did you get into doing this again and again and doing it well as you did?
Well, it was a lot of collaboration. A lot of us in the field were embattled. A group of us, and this group generally coalesced, and you can see a lot of the early clinical trials, be it the early stent trials or the early atherectomy trials and the like. There were a group of individuals who were really trying to really improve the product, and we supported each other. But there was the thing about angioplasty, especially before 2B3As, not sleep great on the night of an angioplasty. And you certainly didn't do more than a couple a day. And you had to really and this goes today, you talk about CTOs, you really had to be confident in your indication. You had to be able to justify what you're doing. The patient had to have a net benefit from what you were doing.
Sure. So essentially, some of the the key things we do haven't changed in several years, but and the dedication is one of them. Now, what led to the next step? So initially it was balloon stents, multivessel, then calcium bifurcation, CTOs. So how did that course go, and how did one technique or one lesion help to learning the other parts of the lesions?
Yeah. Well, I mean, I always had faith that we could replicate the surgery. That faith has still not been totally justified, but in some ways, in many ways, it has. And I believed we had to do as good a job as the surgeons. And that meant, not leaving major branches behind. I mean, there were a lot of people who said, "Oh, it's a diagonal, leave it alone." I said, "No, if it's, a 3.5 millimeter diagonal, the surgeon would bypass it." And that's actually what led me to CTOs. I said, well, a surgeon wouldn't leave this behind. You want complete revascularization. I did believe, sorry, in the ischemia hypothesis. And to realize it, you needed complete revascularization. I mean, the patient's needs can't be, you needed complete revascularization. I mean, the patient's needs can't be determined by your capabilities. You've got to identify the needs and grow and expand your capabilities to meet those needs.
Perfect. And then along the same lines, there is a risk, right? And some of those days it wasn't successful. Even today, many of the cases
Well, I
CTOs are
mean,
not
these
successful
are,
either. So how did
these
that
are
affect you, and
emotionally
how were you able
wrenching.
to push through these difficulties
And,
and the failed cases or the
also,
complications?
the encounter back then for an angioplasty was more, not that we don't, see them in the office and talk to them about it, but you're basically now preparing for something that's a little bit more scary than a dental procedure in the majority of the cases. Those were quasi-surgical. I mean, the patient was admitted the night before. You had long conversations with the family and the bedside. So, the impact, you was admitted the night before. You had long conversations with the family and the bedside. So, the impact, you had a more profound impact of something when things went awry about the number of people you were affecting. So, the key is, I mean, you had to communicate. You had to be realistic about expectations and the risks. I mean, you couldn't oversell balloon angioplasty because it was meh, so you were always hedging. But even with the more advanced techniques, even with early stenting with the thrombosis rates, you had to be very cautious in what you promised. And there were days when you just wondered why you were doing what you were doing, whether you could absorb it. There were some very, very bad days. It wasn't just a failed case. I mean, the OR rates were substantial. The mortality wasn't high, but it was 1 to 2%. Which, if you're doing a couple of hundred a year, which was a high number back then, that's a death every quarter or so, and that's hard. We're not used to having patients die at our hands.
Absolutely. And that remains hard right now. But how about the experience during the case? Whenever I remember seeing you doing live cases when I was in the fellows course,
Yeah.
20 plus years ago. And I remember you looking so relaxed and easygoing, and I was amazed how you can do this case and be so relaxed. And so is that something that comes natural to you? Is it a matter of the many years of experience? How can you keep, or are you just hiding that you're stressed but you're hiding? How does that work?
Well, look, I mean, there's always some anxiety about, especially for instance, back in the days in TCT, I was doing we were doing like 15 cases from the labs, and I was doing 4 or 5, and obviously they were specifically curated to be interesting. That is high risk. So they create anxiety. But on the other hand, it's you know, hopefully you're comfortable enough with the technique, then you can focus on the learnings. And also, honestly, during live cases, I enjoy the interchange. You have panels, you have some very, very bright people making contributions, and just the aura and the interest, especially like at the fellows course. I mean, that was a privilege to be doing live cases for fellows and for anyone for that matter. So I think it was, we did enjoy them. I mean, a funny part of it, though, a little sidelight is I used to do a fair number of live cases with Paul Tierstein. And Paul is wonderful, as you know. But we had a pretty funny dynamic. We didn't agree on everything, but there was a lot of humor. But I remember we got critiqued one TCT because we were too funny. So we became a little more somber. But I think you should enjoy it. I mean, I hope people enjoy this work. I do to this day. It's very gratifying.
Yeah, absolutely. And I think that shows as well in the live and the non-live cases that you do every day. How do you incorporate the new things? So things, as you said, have changed dramatically, and continue to change. So how do you learn the new things that come out? I know you have to test them for some of the companies come early, you have early access to these devices, but how does it feel getting something new and different from what you're used to?
Well, as I always tell the companies, if there's a way to make it go wrong, I'll find it. Okay. So, but I won't hold, but on the other hand, you have to accept that these are early stages at beta testing or earlier. They're not perfect. And you've got to be a participant. You got to be part of the team for the improvement. You can't just wait. You can't have the expectations that the product is being delivered to you whole. It's not by definition, and you have the responsibility both to the patients and hopefully mankind, if this is a product that can actually better outcomes, and also to your partners who are industry, and they're our partners. They build the tools that we use. So I embrace it. And really try to do a pretty rigorous comparison to if they're trying to substitute for something that we use on a regular basis, they have to really prove their mettle. But on the other hand, there are a lot of companies who stepped into big gaps in our needs, and those I frankly ran towards.
Perfect. And then you've taught so many people, you continue to teach people both in the cath lab every day, in the courses and everything else. Now, after you've seen so many people train under you, can you say, look, this person is going to be a great operator, a great interventionalist, or not? Or it's still not as clear?
Well, I think, the good news is, obviously we had one of the first, CME, ACGME fellowships. And so I've been training, these people, interventional fellows for a long time. And fortunately, I think most of them, almost to a person, they've done very well. I can cite maybe one or two, but there are exceptions. I think, look, there is an intuitive talent that goes with it. That can make you really a great operator. We can point to our colleagues who are just, amazingly intuitive and technically with technical finesse and insight. Those people stand out. But on the other hand, there aren't that many of those who come into the cath lab that way. But I think if they're studious and attentive and really take feedback, I think people can become very good operators, especially if they think things through. For me, it's the plan for me more than the execution is actually, I think, the most important part. Because frankly, the tools are pretty darn good now. You don't have to struggle to wire that often. And, with your textbook, you can probably, you can solve almost any problem just reading your book. So,
well, I wish it was that simple, but but in terms of the fellows again, what is the thing that is most difficult to teach them? Is it the wire manipulation, the equipment, the mindset, the approach? What is the hardest thing?
The body is not going to take care of you. You have to be tremendously respectful, and a lot of it is the light touch. People push. I don't push. Things are supposed to glide. Obviously, knuckling a calcific proximal cap is one thing, but most of it, things are supposed to glide. I think of it like everything should be like when you float your swan up. It goes through the valves, not touching anything, going into the PA. It goes through the valves, not touching anything, going into the PA. That's how your wire should go. That's how your equipment should go. That's how your sheaths should go. And that sometimes takes a little learning.
And then when it comes to the teaching through the meetings, so you've been obviously involved at TCT for so many years, fellows course, you name it, so many courses. what is the impact of this, you think, over the years in people learning, not
Yeah.
only the fellows, but also the grown up, so to speak, interventionalists? Actually, many of them don't
Yeah,
have
I
other
think
avenues
it's
to get their
interesting,
continued education
especially
and
you look at
exposure.
TCT and how it evolved. Obviously, there were live cases, but there was a lot of didactics, tons of didactics. And if you really look at the program now, it's really evolved into a very heavy case-based learning. And I think that's where that's where you get most. I think that's where you get most of the bang for your buck, especially if you structure the cases right and the branching off of learnings that come from that specific case. And people enjoy them, and that's something people can take home with them. They can go home and say, at least for these 3 days, I learned these three things, and I'm applying it like next Tuesday on a case, and I'm a better operator for that.
Perfect. And that brings us to the actual term chip.
Yeah.
Is when you talk about the term chip, people think chip shot, right? People think it's going to be easy.
Yeah.
But actually, you coined the term, right? Complex high risk interventional, or the abbreviation changed from time to time. But what made you think of that, and what made you baptize the field that now it's becoming the standard acronym we use around the world?
It's kind of funny because it was Marty, IJ, and I were sitting around, and I don't remember if it was my office or Marty's office, whatever. We're right next to each other. So my Wi-Fi is turned off, so my geolocation is a little loose. But I'll just say one of the strategic companies came to me and said, "Well, we want to turn downs." And I said, "Well, that's good, but it's up there. I mean, my life is as a sort of third or fourth opinion is a much broader range of people who have been just told no option. I mean, I see no option patients all the time, and the vast majority actually have options, as we know. So why don't we why don't we expand the concept beyond just surgical turndowns into the much broader range of individuals who are considered too high risk to do?" And we're in New York, where obviously there was a lot of risk aversion surrounding us because of the perception of the database and the database and the impact that might have, which actually it's had no impact. I mean, fortunately, in terms of individuals. And then we were kicking around the acronyms, and I think Marty might have let it off, but we walked out of the room with complex, high risk interventional procedures, and then got modified, indicated procedures. IJ wordsmithed it, but that's where CHIP was born. Though I do enjoy the fact that there were other people who actually say they were present at the time, but I don't remember anyone else in the room. So it doesn't.
Well, this is great because also, then there was a circulation paper, and that really became kind of the baptizing grounds. And I go to Italy now, France, all the meetings in the world, they use the term chip interchangeably. So that simplified the thing and made it much more understandable, I think, for people. How can you actually get on doing all this? So you do still all these cases, you still all this teaching. So what is the secret? How can you keep in good shape to physically and mentally to be doing all these things?
Well, first of all, I'm lucky. My mom passed at 94. My father's still alive at 98. So we're kind of durable. Um, but also no. But look. First of all, it's the innovation. If you want to stay in your lane and do what you like, over and over again, that's fine. But for me, it's the excitement of the learning, and also just teaching the fellows, clinical trials. There's just a lot of not. There's just so. I mean, it's a golden age now. There's so much going on. Whether you look at the pharmacology or the devices or how the whole interventional field is spreading into whether it's renal denervation or heart failure. I mean, that's amazing. So and that's fun. On the other hand, you have to. I mean, I'm not an exercise nut, but you do want to stay in some sort of a shape and just exercise. I like to exercise my brain, not just by reading journals, but I love history, and I reward myself with when I catch up on my journals, so to speak. I reward myself with a fun book. Fun book for me might be history of Rome, but that's not fun for a lot of people. But that's fun for me. And also, I like tennis. I love skiing. Just feeling in touch with yourself and your body, and that's the physical part. And obviously, family is a huge part of it. And frankly, one of the reasons I keep working is because I have a very large family. So,
Well,
but
this is
that,
perfect, and that keeps you, as you like, keeps you engaged.
yeah,
Do you have any favorite books or any favorite movies?
yeah. Yeah, it's interesting. I think the book that I've read that's impacted me the most in the last couple of years, it's a little book called The Swerve, which is really about the rediscovery of a Roman poem by Lucretius called On the Nature of Things. And it's a brilliant poem, really expressing the Stoics and the atomists and their whole attitude towards life. Excluding the gods, obviously in Rome, the nature of love, the nature of humanity, and it's really a humanistic poem. And the rediscovery of that, as you follow the thread in a monastery where a lot of these old classics were rediscovered, changed the course of history. People found little pieces of it. It impacts so much of the Renaissance, and I find that's just one of those accidents of history that literally changed the world. So that was sort of a fun one. As far as movies, sorry, I love movies. I actually ran a film society in med school, but it's interesting. If there's one thing I'd watch over and over again, it's called L.A. Confidential. It's not one of the great, I don't know if you've seen it. It's a great movie. It has Kim Basinger in it and a whole bunch of great stars. But it's set in L.A. in the 50s at the dawn, when the West Coast was just post-war coming into its own, very novel, and it just has a great sense of time, very textured and nuanced, more like a novel than a film. So that's just something that I just can't get enough of it. So those are two of my favorites.
Wonderful. And then, in terms of you said before that you try to keep active and exercising and everything. How about the radiation part? Again, you were earlier on where the X-ray machines were not as good,
Yeah.
and now still we do longer cases. How do you deal with that, and has it affected you at all?
Well, I was very fortunate, even when I was at Cornell, to be working with a physicist named Steve Balter, and he literally founded the field in cine angiography, because if you look at those ISO exposure diagrams in the old textbooks, those were his in the C arms of some, and we partnered up. And actually, it's interesting. We're actually reviewing a manuscript now. We've worked very hard in terms of radiation reduction strategies. A lot of it is his input. Mine just is sort of implementation. But now we've looked at like 100,000 cases over a decade. And the message, actually, of what we're going to promulgate is obviously the equipment helped, but most of it was the doc's behavior. So I've been very assiduous and meticulous about that. I have to say I'm also conflicted because I'm also involved in a shield company. So we'd like to eliminate the radiation for the docs, of course, but we've also focused obviously on minimizing the radiation for the patients.
And
Uh,
you've been okay in terms of the lead, and people
One of the
have
reasons
issues
I
with the lead and the
exercise and do
weight, but
Pilates
that
is
hasn't
because
affected you.
without that, my MRI is not pretty from L1 down. I'm going to knock on something here. It's not wood, but fortunately, I did have about I guess in '08 or '09, I had a major back issue and was able to rehabilitate and maintain the core strength that's necessary. But I think going forward, as if these technologies really come to fruition, I think hopefully the next generation really won't suffer all these terrible orthopedic issues.
So, Jeff, you made a huge impact again in many patients, in many other cardiologists, in various stages of their careers. What are you most proud of about the things you've done so far?
Well, I think professionally, I like to think I've been involved in three programs. Excluding Cornell, but we moved to Lenox Hill when it was officially the worst program in New York City. we built that into a powerhouse with collaboration, with innovation, working with friends who were like-minded. When we moved up to Columbia, it was, it was a ghost town, and we were able to build that up into a major center for clinical outcomes and scientific research. And then several years ago, went to St. Francis and partnered with Richie Schlafnitz, and that's also grown. So I don't know if it's cause and effect, but it's an association that I've been with three programs that have all grown to have a major impact on the field. And so professionally, that's, I think, I point to that with pride.
Well, I mean, if there's not three accidents in a row, right? I mean, these things happen for a reason. So clearly, it's a lot of work that goes into them, and a lot of planning, and a lot of care in growing them and making them successful down the line. But how about personally? What are you most proud of personally?
Well, we have a very close knit family. I have four, actually, sort of four and a half kids. I won't go into that, but I do. My daughter has custody of a brother from another marriage. He's part of our family too. So we're it's sort of a fun age. They're adults now. It's sort of like grow your own friends. So we're pretty, we're pretty close. We have a house together in the Hamptons. We're all together in the city, and I like the fact that these are kids who grew up on Park Avenue, who could have been spoiled rotten, and actually are very wonderful contributors to society, good people, caring people, and also know how to have a laugh.
Absolutely. And then, what are the things that you are most excited at this time? What are the things that drive you going forward?
Well, I mean, I think I'm involved in many in terms of professionally. I think we're involved in several, I think critical studies, especially with unloading, whether it's obviously protect or is door to unload, which I'm actually on call for right now, and this patient being enrolled as we speak. So I think that does excite me, and also. Maybe just cementing my legacy with more with teaching fellows and having them sort of push the brand out there.
Wonderful. And then, do you have any plans of slowing down, or it just keeps on accelerating down the line?
Well, I'm trying. I'm trying it. I'm trying to. We'll see. I mean, I think I have a plan. I won't say it now, but I think I do. And it's nice to have two homes. Let's put it that way. And that's sometimes a good thing. Sometimes it can be a dilemma. I mean, I have a lot of devoted people who I work with closely at Columbia who really don't want me to go anywhere, and same at St. Francis. So I don't know if I can manage both of them indefinitely, but we'll see what happens in the next year or two.
That's perfect. Well, as you said, your father is, if I remember, 98, right? So there's a long way to go there.
As my mother would say, from your mouth to God's ears. But
So, and then just to get your final kind of pieces of advice. So, since you've seen it all pretty much done a lot of things, for the people who are starting now, the early career, the interventionalists, the interventional fellows who are early on, if you had to summarize, what would be the key things you would advise them to do to have a successful career in life?
First of all, be humble. You're very blessed. You're in a great profession. Every day you can go home and feel good about yourself because you've helped another person. So you should appreciate that. And but also in terms of how you approach the patients. You want to be giving. Constantly improve. Never think you got it, that you know it, because Mother Nature will always come up and bite you and show you who's boss.
Wonderful. Well, Jeff, again, I cannot thank you enough. Thanks for spending the time today. I think many people who watch this will get some very valuable lessons down the line. Thanks for being there, and look forward to working with you for the next 30, 40 years, it looks like.
Okay. I won't agree with that, but a few more. Okay. Matt, it
Sounds
was great
perfect.
seeing you.
Thanks
This
again.
is
Thanks so
wonderful.
much, Jeff.
Bye-bye.
Thank you for listening to the Sensei podcast.